was in a rural setting, a lot of them didn't have internet. They didn't have this. So I PPE'd up. I put on face masks, all of the gears that I needed to go in. And I went to the home. I either took them an iPad and I used my phone so we could communicate. And I go back to my car to make sure we got what we needed done with this research. I was able to get accurate readings and documentations for that. Our aim one was to compare clinical outcome of the participant who received. John, is that you moving?
Yeah, I'm trying to make it bigger.
Oh, okay. I got to admit.
But I'm not.
Okay.
Do you want me to read it for you? Do you want me to read aim one?
No. I got this part. I'm gonna get through this. The management, education, and monitoring for the community health worker. So through this telehealth to participate and receive normal standards of care. Our aim too was to assess difference in patient satisfaction, patient self-efficacy, and patient self-management between the patients who receive cardiovascular disease risk management education and monitoring from the community health workers through telehealth and who receive normal standards of care. My aim 3 was to assess feasibility of the telehealth model delivery of the effectiveness and evaluation. Okay, that's great, John. You have to do it anymore. From perspectives of the patient and the community health worker. Anyway, with this, I can't really see that, but the results showing there was high participation and satisfaction with the community health workers, education, and risk monitoring. Almost all participants, 98% either was strongly agreed or agreed that they were able to communicate adequately and with the community health worker, 97% comfortable that the community health worker was able to understand their problems. Over 98% either strongly agreed or agreed that they were able to communicate adequately with the community health worker. Almost half of the participant, which was 46%, either strongly agreed that the telehealth made it easier for them to communicate with the community health worker, with 3.2% nothing that they would have received, noted that they would have received better care if they had been in person with the community health worker. The focus group that was placed on the end with the patients that the community health worker didn't have a clue about is experiences and reported a high level of patient satisfaction with this study that I done. And this was published in the Mississippi Public Health Association for me. So we got a chance to get published, but it was a great outcome. It was a great research. The community was just thrilled about it. The participation, I had elderly, I had young, I had, just everyone. And I had a lot of male participation, but the bulk of my participation were females. So if there's anything that anyone would like to know about this research or anything else that you're interested in finding, you can always ask questions if you like at this time. If something you want me to elaborate a little bit more on, I would be happy to do so. Michelle?
Yeah. So I'd like to know how many participants did you have? Go ahead.
Okay, so we started out, it was supposed to be 120, but I actually only got 180 because it was two of us supposed to have been doing the research, and I ended up doing the research on my own. And because of COVID, I had to cut back on some of the participants that I was working with. So 180 was pretty good.
Yeah. Okay.
Where did you? Oh, there's another question, I think. Oh, that's Michelle. Okay. Where did you present this, Maddie?
I presented this at in Boston, Massachusetts. And I also presented it at in Mississippi at the conference there at the Mississippi Public Health Association and at the National Public Health Association.
That beats fit for one here.
Can someone have them mute out the baby?
Can you tell who it is?
Yeah, hold up, I'll tell you. Maybe Stephanie?
Okay,
Well,
thank you.
I'll try.
The bottom right-hand corner has a circle. You can toggle to zoom in.
Okay, yeah, I figured that. So a couple of things that come to mind about this study is, yeah, the pandemic in my community in California, the pandemic pushed forward, promoted a lot of new thinking about healthcare. And our community health worker in Monterey County really got off the ground in the middle of the pandemic. So if there was anything positive about it, we had to get creative about healthcare. Sounds like you did too.
Yeah, absolutely. I mean, this is a research study that I think every community health worker need to kind of like take advantage of and do in their communities, because it kind of helps you get familiar with the community people, the needs of the community. Also, if you're looking at hypertension from a hypertensive perspective, you're thinking like, okay, so with hypertension and a lot of other chronic diseases, the first thing we're going to think about is cardiovascular disease. So when we want to focus on that, we want to make sure that we're out in the community doing all that we can to make sure that our community is healthy. And so this research was just a resulting from implementing just that cardiovascular disease part with the community health work effectiveness study during COVID-19. Thank you so much, John.
Yeah, and then another thing that strikes me is it's a community where there are healthcare disparities. And again,
Yes, absolutely.
If it's great if we can sort of change the regular thinking in terms of how to reach populations. But I think what stands out more than anything else is how satisfying this care was. Your satisfaction scores for community health worker care were off the charts.
Yes, it was great. We got really high feedback in the community, even though it doesn't seem like it. Our community, people are really concerned about their health because we are like in an area where we don't really have great health care. So every opportunity to get to educate them, to work with them, they kind of jump on the wagon just to get that. So especially when things are free to them. Now, there were some incentives, but it wasn't for them to do the study, but it was just for they didn't even know that they were getting it once they finished that survey, because some of those surveys that we done was pretty lengthy and it asked a lot of detailed questions that I had to ask, and and they were willing to go through that process, because anywhere from the first month I might have had to do it might have been 60 questions in a survey, and you had to do 60 questions with maybe 3 times within 3 months, span to get, the results and to get the, the participation from the community or from the participants that participated in this research. So it was interesting. It wasn't an easy task. Definitely hard, but I was dedicated to what I was doing to get it done, and I wanted to see it through. So that's why I stuck it out and I got through the process.
And then the last thing I'll say before we break is, go ahead, was there another question?
Thank you, Lindsay.
Before we break is, there was similar research going on in California about how do community health workers help with asthma care. And the outcome, I don't have the data like you presented with us, but so many improvements were seen in correct use of asthma medications, the rescue inhaler, the controller inhaler, and when to use the emergency room. Emergency room visits went down in this study, but the big thing that patients liked was having a chance to talk to someone about their asthma control and when to stop the rescue inhaler, when to kick in with the rescue inhaler. The study was so beneficial, it showed such good outcomes that the state of California Medi-Cal decided to add billing codes for asthma care. So right now, community health workers can, or the institution that hires community health workers can bill for asthma visits, including asthma home visits. So my point is, there's real active research going on in this arena right now. That is how community health workers are satisfying and effective. And I'm encouraging all of you who are attending that, get to know your job in a curious way. Always be asking yourself and asking your supervisors, how do we know what we're doing is working? Do you think we can study that? Do you think we can do a study about that? I think there's funding out there for programs like this. Okay, so we're about only 10 minutes beyond the first hour, so now is break time, and my clock says 7:10. Do you think 10 minutes is enough? The next session is going to be very interactive. So you want to come back at 7:10, 7:20 or 7:25? I can't see the chat.
7:20, 25. Sound good?
Say again, I'm sorry.
15 minutes was good. Yeah, 15-minute break was cool.
Very
Whenever
good.
y'all
Okay.
ready.
So go take your biological breaks and we'll see you at 7:25. Thanks,
Right.
Thank you.
everyone.
Thank you
Thanks,
all so
everyone.
much.
All right. See, I knew that I couldn't, in terms of your slide, I was not able to get my daughter over, Maddie.
Oh, that's okay.
to
It was
insert
fine.
the-
I kind of went through the shortcut, and that kind of helped me to even do more without actually having the slide there. So it's fine for me. I just wanted to kind of like fall through the sequence when I'm looking at it, and that's the way I kind of flow
Yes.
through it. But I need to flow through it without the sequence, just to go through it anyway. But it helps me out a lot just to see the slide. But I'm good. I was good. So
See,
you did
that's
well.
what-
Thank you so much.
You see, that's Murphy's Law. I have been having this slowness problem all day with this computer. And I tried closing some programs to make it go quicker, but right when we needed it most, it failed. The speed
Oh
of
no, you did an excellent job. You did well. So no, you didn't fail. I didn't have a problem with it being slow. It kind of gave me a little chance to kind of like reach back and to think about some other things that I didn't share that I did do. Monitoring the BMIs and all of that measurement, even thinking about the baseline when you have to do the A1Cs, the blood pressure, the glucose,
yeah.
the weights, all of those things was a part of that research. So we had to do that in the beginning, to get what we needed done.
Yeah.
So all
And
of it was
these are-
very, 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 very good. So thank you so much. And
These
that
are
just
all-
make me become more stronger than what we were doing. What'd
And
you say?
this is all part of your knowledge and tasks as a community health worker, right? All of those things.
Absolutely.
Yeah. So I'm sure that your example is shining to some of these students. They may or may not be doing all the things you do, but the goal is to get people there.
Yes. And the thing so with that, John, is that they don't have to do it on cardiovascular disease. It could be whatever in that community that they're at, where their community have the most need in, whatever chronic condition that's going on there that they see most. They might want to do a little research on it and kind of do some identifying that could see where the causes are and where,
Right.
what needs to be done. I mean, the research doesn't have to be centered around minds, but just around
Right.
something that's going to help them do identifiers and do control and prevention, methods, use those methods in their own communities. So that part.
Yeah. That's why I mentioned the asthma.
Right, absolutely. And I appreciate that.
And that wasn't in this community. That was in a community further north. It was a more
Right.
urban. It was a more urbanized community where there's more asthma problems. It's not a big issue here in Monterey County.
Right. So what did you think about, what I was gonna ask you? What did you think about participation? Wasn't it great?
Yeah, yeah, I think we're getting better at I'm getting better
Oh,
at,
you did absolutely wonderful. So
at
yes,
eliciting participation. Hopefully we'll see more faces for the second half here.
right.
Hopefully, and
Hopefully.
it's important for the interactive piece that people show each other who they are. So, all right, I'm gonna go. Did you hear my dog? I didn't hear your dog. I heard my own dogs barking.
My dog is asleep and I don't want to wake him.
All right. I'm gonna go head out and make sure they're not tearing the place up. There's nobody else.
Okay. Okay. Awesome.
I'll be back in less than 10 minutes.
Okay, sure.
Hmm. You know what? I'm gonna have to put everybody in the same room, Maddie. And we're gonna have to,
Let
we're
me
gonna
see
have,
what I'm seeing over here. Okay, it's saying 7 join, 8 then join room 2. Let me see
yeah,
who
I
all
can
in.
only,
Not now. Let me see,
I'm
11
putting
and
every,
join room 2.
I'm putting everybody in the same room. I think that's, and then we'll have to work it with them. I can't believe all the challenges I've had today.
Yeah, it's been many, but it is what it is. You doing well. You handling it pretty good, so no problem there.
Okay, let's go into room 2.
I don't even have an option to join rooms.
So you're unassigned?
Yes.
Oh my God. Okay,
No,
well,
no. I got an option.
okay.
I'm gone.
Yeah, I think you're right.
Here we go. So it didn't work this time around, breaking people into rooms. So let me drag the questions in with us.
Okay, John.
I'll put the questions into the chat box. So oh man. Now I'm running into the I'm running into the beach ball scenario now.
Oh, geez.
We're in
Tell me.
room.
Why don't we just go back to the main room and just work it out there?
Yeah.
Here we go. Let's try to work it out here. Oh man.
It's gonna be okay. We're
Can
gonna
we just
get
make
it.
it a full group activity?
Yeah, that's what we're gonna
We all
do.
just do it together?
Yep.
John, we have one unassigned participant
Who is that?
in the breakout room. I'm going to look. Unassigned one. Let me see who it is.
Okay, so here are the prompt questions, and we'll just go. Oh my God. I'm losing confidence in Zoom.
Oh, no, don't do that. We're good. You're good. You got it. If you don't mind, I mean, it's the same as being in a breakout room. I got it. I got it. I got it.
So I think it'll work better if we close this room and go back to the main room.
Yes, absolutely. Because Stephanie is over there by herself. Well, I just assigned her to room 2.
Okay, so I'm gonna close the room, and in 60 seconds, in 60 seconds, it'll make you go back to the main room. Here we go. If you can go over there earlier, go. This has not happened before in the breakout.
No, we really haven't had that much of a problem with the breakout session. So it's definitely something going on there.
All right,
Well,
so
it's been popping in and out the whole time I've been on this. It'll just black out and then it'll all come back in. So it's not just that.
yeah. So
Right.
here's the question, you guys. I hope you remember Rosina's case, and we'll throw each question out and have 5 minutes talking about it. Maddie and I will try to stay out of the conversation as much as possible, so you guys can learn from each other. The question number 1 is there a history of chronic disease among your family and friends? To what extent does diet, patterns of exercise activity, tobacco, alcohol, and other substance use influence their health and risks for chronic disease? And you can answer that question from personal experience or community experience, that is experience of friends and family, or you can answer it from Rosina's perspective. Got it? So, to what
John,
extent?
can you
Go ahead.
copy and put them in the chat box for them so they can at least see them? If you can, if you can't, don't, that's okay.
Yeah. Okay, let's try it this way. Thank you for that. Darn. Just when you think you're getting good at something.
You're great. So it's
All
just
right.
the internet. So don't even worry.
Here's the question. In the chat box, question number 1. Is there a history of chronic disease among your family and friends? To what extent does diet, patterns of exercise, activity, tobacco, alcohol, or other substance use influence their health and risk for chronic disease? Either from your own perspective or from Rosina's perspective.
I'm sorry, can you say that one more time?
Can you see the chat box?
That was in the chat box.
Yeah,
Mhm.
the
Okay,
chat
got
box
it.
is, that's what we'll do.
I
I can see
honestly
the
don't
chat
see it,
box, but I
John.
don't see the message.
Yeah, there's
I don't
nothing
see it
there.
either.
Yeah, so,
It's not in the chat box.
yeah, I've not seen it.
Can you share your screen again?
Thank you. I'm pulling hairs out over here, so thank you.
Thank you
There-
all so much.
There
There
you
you
There we
go.
go.
Perfect.
All right. So who wants to get us started? I have a sister. I was saying I was going to be quiet, but I'll get the ball rolling. I have a sister that has a chronic disease called multiple sclerosis. And she's single. She has always lived by herself. And she never really learned how to cook. So she eats out a lot. I'm going to leave it at that. Sorry, sister, for bringing you up here.
Yeah. Oscar, my dad has high blood pressure. He has 7 kids. That probably he put himself last. So I think environmental, plus poor eating habits. We ate out a lot. He had a quite somewhat sedentary life. He had an office job, and he commuted from San Diego to Downey, Los Angeles area for 25 years.
Wow.
So I think that impacted his health. He would try to go to the gym as often as he could during his lunch break, but I think overall, the environment, the eating, the lack of consistent exercise all impacted his health.
The
And
commute,
so, mhm. He would have a lot of chips because it would keep him awake on the drive home. Because by the time he retired, it was a 3-hour drive there, a 3-hour drive back. He's doing much better now, but still takes his blood pressure meds daily.
well, I'm happy that he's doing better, huh?
Yeah,
Yes,
thank you. Me
absolutely.
too.
Thanks so much for sharing, Leslie.
I'll go
Cheryl,
next.
Cheryl has something.
I was just saying that within my own family, we don't really have a whole lot of chronic conditions in common. We have asthma, but I do see a lot of like diabetes, hypertension and stuff in my friends, but I notice a trend that, they're all generally sharing the same diet and lifestyle, like lack of exercise and stuff as the rest of their family that they share those conditions with. So I think a lot of times it's, sometimes it's genetic, but a lot of times it's just because of that shared lifestyle.
Mm-hmm.
Mhm. Thanks, Cheryl. Philip?
Yes. Hi. So my mother actually passed away from COPD. And my father,
Okay,
he
good.
suffers from hypertension, high blood pressure. Both of my parents were, heavy smokers. After my mom's passing, my father was able to successfully give up, his nicotine habit.
Mhm.
I will say that throughout my mother's struggle and seeing her eventually having to take oxygen 24 hours, and then, as it entered the final stages of hospice and administration of morphine, upon her passing, what was interesting is she was smoking up
Mhm.
until the day she passed.
Mhm.
She had actually cut out little sections in her bra where she would hide little cigarette butts, and unbeknownst to us, I guess she would during bathroom breaks, be taking a hit or two. So that's pretty much it on my family history.
Wow.
She was creative.
Very creative. I just had a friend, not a friend, patient, that's a smoker. And every time you ask her, what are your goals for yourself? Her goals is, I'm gonna quit smoking. I'm not gonna smoke. I've cut back on cigarettes. I've done this, I've done that. I'm not gonna smoke. Then she has COPD. She's a diabetic. and she's hypertensive. And so just this past Sunday, she got on the highway, she actually couldn't breathe. So she drove herself to the emergency room, which is 35 miles away. And
Wow.
without breath, and you know, the pain was excruciating. Someone managed to call her and she answered the phone, and the person stayed on the phone with her until she made it to the ER,
Mm.
which was just so, I mean, you know, that was just mayhem waiting to happen. She could have lost her own life in the process, causing someone else to lose theirs because she could have passed out. And you know, one simple call, "Hey Maddie, I'm not doing well over here. Can you at least come check on me," or whatever. Then I would have known to call 911 and
Mhm.
got the help that she needed. But instead, she decided to take herself, and she came home. She was in the hospital for about 3 or 4 days because she couldn't breathe without oxygen. And every time they took her, her sat dropped really low. So once she got stabilized, not having cigarettes for those days, she was able to, you know, be released and come home. She got home, so I went to do a follow-up visit, and the only thing I could walk into was cigarette smoke. And you just almost lost your life, you know. So I don't know. Some people's, you know, they don't get it. So with that, for me, it was difficult because I know where she is and the stages she's in. I mean, she's walking around with an oxygen tank. She's got pumps. She's on a nebulizer. So it's a lot of, you know, things that going on. And it's like she's not really taking that seriously to me about her health and her life.
Wow.
So unfortunately, tobacco is just it's one of those habits that's really hard to kick.
Mhm.
But also, many times tobacco users will not be upfront with their providers and let them know that they actually smoke. So when they're placed on medication, whether it's for diabetes or hypertension or whatever it may be, they don't realize that the use of tobacco is actually counteracting the medication. So it's like if they're not even taking any medication at all. My stepmom, she's a smoker. Fortunately, she already kicked the habit. But she is also diabetic. And for the longest time, she kept complaining about having to take her medication and not being able to control her numbers. But it was really because the tobacco had that effect on her and her medications.
Mm.
Some of the good couple of points here. Some of the best data in health have to do with smoking cessation. You can, if it's possible, if you can really get a patient to stop their smoking in a matter of months, their production of cough will get better, and then within years, their emphysema and their cancer risk will come back. So it's very strong data if you can the benefit of smoking cessation. And that kind of leads to question number 2. So I'm going to put question number 2 up, which is there a history of chronic disease in your family? Do you believe that their state of mind or emotions affect those people's health and their risk for chronic disease? And one of the things that I thought about when the last person was talking was the stigma of smoking and not sharing it, thinking the doctor would stigmatize the patient. And, you know, all the psychological consequences of stigma.
Well, I think in general, it's hard for me to answer this specifically, but I know that our minds are very powerful. And when we put our minds to change and behavior change, it's possible. Now, will that take away a chronic condition that someone has, or at least improve it? I think, you know, more exercise, change in behavior, depending on what it is, could make have a positive impact. But I don't know. So I think it does have an impact on overall health, or at least managing it at a different level when they have the right mindset and the right support around them, because a lot of it's environmental. Someone might be wanting to make a change, but if in their environment they don't have their needs, like, you know, we do estos a lot, and if they don't have the proper food and we're telling them to eat better, or they have a mindset of wanting to, but they don't have access, it really can be a challenging thing. But I think our minds are very powerful and we're able to do a lot.
Mhm.
But yeah.
So there's a couple of, thank you, Leslie. There's Benice has had her hand up for some time.
In
So
Quarantina.
please, and Corintia right after. Benice, please help us.
Yeah, I do think our minds and emotions affect the health and the risk, specifically stress. Stress, of course, can inhibit higher blood pressure, but also inhibit higher cortisol levels. That kind of tweaks a lot of stuff in our bodies all over, whether it be mental, physical, bloating, you know, facial stress. There's just so many, you know, things that go into that. And personally, I see that with my grandmother. She has high blood pressure, and she has a lot of stress because she's a great caretaker for my great grandmother. And
Wow.
she doesn't know how to cope. And I've suggested, you know, over time, like maybe going to therapy. She's, you know, had a hard life, and that's something that she doesn't want to do because of the stigma, you know, from her generation of, you know, that being for the crazy people, quote unquote, and things like that. So I definitely think it does could have some very adverse reactions when it comes to your health.
So thank you. You bring up some
Great.
very good points. I know we're going to get to Corintia, but Benice, are you familiar with the term toxic stress?
Semi, yes.
So there's supposedly good stress and toxic stress. And cortisol is the chemical that the scientists believe. I think you mentioned cortisol, didn't you?
Yes.
That's the body chemical that scientists believe is responsible for toxic stress. So and toxic doesn't sound good, right? It affects other organs in the body. So Corintia, please share with us.
Yes. So essentially, in regards to the second question, in my family, there is a history of chronic disease on my mom's side. She is prone or is diabetic. She was diagnosed a couple years ago, actually, and she's been just trying to manage that, and then now hypertension as well. And as the older she gets, it's becoming a little bit more tougher for her. But I think for her specifically, her emotions often get in the way of controlling or basically maintaining a healthy lifestyle when it comes to her diabetes, just for the fact that if she doesn't feel good, or if she knows maybe perhaps her glucose levels are a little higher than they should be, she often doesn't like to go ahead and make appointments or go to her, primary physician, just because the only thing that she thinks about at that moment is like, oh, I'm gonna go in and they're gonna be reprimanding me and just telling me like, oh, I have this and this and this. And it just makes her not have that motivation to seek that care and perhaps that advice from a medical provider. Luckily, however, she has kind of changed this mindset in the past couple months. She has been able to successfully maintain, those blood glucose levels, for example, because she's had a lot of really great providers that have allowed her and they have helped her be in that journey to maintaining stable levels, whether that be taking her medication like she's supposed to, which she often didn't do in the past, or just the little victories in the process have become a big motivator, and she's successfully been able to change that sort of mindset up till now. So I do think in my case, for example, the state of mind or the emotions of a person can definitely affect their risks.
Great. That's awesome. Liz is in the chat, John. She says mental illness runs in my family. The stigmas definitely affect their treatment. And Nora said they may feel ashamed.
Mhm. Lindsay, how does it affect their treatment specifically?
It varies for each person because mental illness in different forms runs in my family. So like I have a uncle who's schizophrenic and his parents were, very religious and old school and felt kind of ashamed of that. So he didn't get proper treatment and that led to pretty bad outcomes for him. And then it's there, everyone has a different thing. It's kind of crazy. So like my mother has narcissistic personality disorder. And one of the things that's common with that is that you can have Munchausen's by proxy towards your children. And it's more of like instead of their traditional where you fake illnesses, like physical illnesses, it's more psychological illnesses. And so from a young age, she was putting psychological illnesses on my brother, sister, and I. And so there's a whole stigma to that. And then like, it's kind of hard to tell people about that. And so there's just a lot of complexity in it. So there's a lot of stigma around it. It's hard to talk about things that happen to you from other people's mental illnesses and the treatment and stuff that you need to recover from that, as well as just seeing how other people have been treated, not wanting to be treated the same. Does that make sense?
Mm-hmm. Just another barrier. And oftentimes the traditional healthcare provider has a hard time with that. And oftentimes the patient gets blamed for the lack of success.
Yeah. And I can give you an example of that. I'm sharing a lot of personal information, but I just feel like this stuff isn't talked about enough. And so I try to talk about it when I have opportunities. And this is one.
Thank you for sharing.
One that she put on me specifically was that I was bipolar, which I'm not. So from a very young age, I was seeing psychiatrists and she was telling them I'm bipolar. And so they believed her. And so I got put on bipolar medicine, which if you're not actually bipolar and you're on these, like you're on lithium and strong things like that, you will have the symptoms of somebody who actually needs these because the medicine is inducing it. And what's something that's very common with bipolar or people who experience it is that it's hard to accept. So a lot of people who have bipolar disorder will go to a psychiatrist and say, I'm not bipolar, you're mistaken, this is a wrong diagnosis. But when you actually are misdiagnosed as bipolar and you're going to a psychiatrist and saying this is a wrong diagnosis, they're going to tell you, no, you are this. And it's just very hard to break free of it.
I sadly thank you for all the sharing that you're doing, Lindsay. I sadly lost basically a second cousin because he got so frustrated. This was back east. He was getting care at Harvard University, but there was a disconnect, and basically he started to self-medicate and went out to his college campus. He'd been suspended from college. He went out to his campus and picked up some pills. And who knows ultimately what was in the pills. But he didn't make it to the next morning. And part of the factor was nobody was listening. It was a hard disease to treat, number one. It was a hard disease to treat. Stigma was at play. He was trying to keep things secret. And he took matters into his own hand. I'm sure you're all familiar with stories like that, sadly. And sure enough, what do you think when they did the toxicology, what do you think showed up in his blood?
No.
Yes, fentanyl. And
Because they're putting fentanyl in everything is laced with fentanyl now that you can get on the streets. Everything has that laced in it. I had a kid, I'll jump. I had a kid, I'm a foster parent, and he was smoking weed, and so I got him in a program because you can't smoke weed in my house. So I'm in a program, and they test you, and he tested for fentanyl. He said, I've never done fentanyl. I'm like, dude, you don't have to know that you're consciously doing fentanyl. to have fentanyl in your system, and he registered it. Luckily, from there, every test thereafter, it would go down because he didn't do fentanyl, but it would show a decrease in the level of it. But they put it in the marijuana, something that simple.
It's tremendously addicting. I mean, it's everybody knows that. And they try to use it to get you to buy more or whatever it is you're taking. I'm going to add another question. Thanks everyone for tremendous sharing. This question is a little bit more on the upbeat side, okay? The upbeat side of chronic disease. The question is, okay, we'll get to you next, Michelle. The question is there a history of chronic disease in your family or friends? In what way do family or friends support your good health? How can family and friends be supportive?
So what I do, I just walk it. How I eat, how much water intake I have. My whole family knows. All my kids are in the gym or on a sport. It's a mandatory thing because I know the importance of it. So, but basically by example.
Yeah. I'm gonna keep it positive. I'm not gonna go down another path. How about Leslie? Your hand is up as well.
Yeah, thank you. So definitely trying to show empathy. I think Lindsay also said that, but what I started doing a couple years ago with my family is, you know, because my parents are getting older and my dad has had high blood pressure, my mom has had high cholesterol, or they have, you know, just group chats every single day, checking in, making sure that they're okay, providing each other with support and advice just verbally. I live in a different state now, so a lot of it has to be done through text. Or when I have gone on walks, I go on walks and encourage them to get up and go around the same time, and we chat on the phone so that, you know, we're keeping busy with you know, and they're being healthy, but we're connecting in that sense. So a lot of it's just verbal encouragement to support that, and trying to discourage things when we are together that are unhealthy, you know, to support them and their health, as well as some siblings of mine that aren't the healthiest either. So it's a lot of just positive encouragement, support, being there for one another. And like Michelle said, try to be that example from afar.
Yeah.
Great.
And it doesn't have to be.
Lindsay has something in the chat.
Sure.
It says empathy, making lifestyle changes with you. And Noor said they can join you in your journey to improve health.
Absolutely. So, and then I believe Venice has her hand raised.
Yeah, also being knowledgeable in your family or friends' chronic disease. Like I was talking about my grandma earlier, she actually had an incident today where she called me like, oh my gosh, my blood pressure is 156/88. And so I, you know, was helping her with the education, how to bring it down. And she was following up with me throughout the day. And there was a steady incline to a point where I told her, okay, now it's time, you know, you need to go to the ER. And after she was released, she was just so thankful that, you know, there's someone there to at least listen and know, you know, that they care. Of course, my grandpa was with her, but still somebody else besides your spouse, and being knowledgeable in what they're experiencing and their chronic conditions, I believe is extremely helpful for your family and friends.
Yeah, thank you for sharing. Maddie, is that something that you've done over the years often? It's kind of being that ally for the patient?
Absolutely. Absolutely. Definitely go out into the community, into the homes, and encourage the participant, you know, to eat healthy, to move more, read the food nutritional values, to monitor sodium, glucose, and all the sodium, sugar, and say that word for me.
Carbohydrates.
Carbohydrates. I don't know how I got that transposed, but monitoring that inside of the food, you know, before purchasing, and to even cook healthier and teaching them to, instead of frying a lot of food and using a lot of sodium, to just like use herbs and spices, to flavor your food, cut back on that salt intake. And those are some of the things that, to help them become, self-managers at home is, it's really good. So that's kudos.
So I have one more question for you, Maddie. I see Anupam and Shahanda have questions which we'll get to, but how can your clients get in touch with you? How does that work at your clinic?
So at my clinic, I have a cell phone. I have business cards that I give out. Usually before I get the client, they are referred over to me from the healthcare provider to my office. And either they're going to be, whatever their chronic disease is, that's how I go out to follow up with them and get them enrolled into my program. When I'm enrolling them into the program, they're getting a whole welcome pack because they're getting educated on how to check their blood pressure properly, how to recognize the warning signs of a stroke. They're getting food and nutritional training, educational pieces. If they require, because of hypertension, they're going to receive blood pressure monitors so they can become self-managers at home by monitoring their own blood pressure. I kind of like train them how to do that. I'm giving them my card because my card has every number, even if you need to reach me by way of Facebook or, text message me, fax me, call me, all of the information is on that card. Everything is on there except for my personal number and my home address. Because they will show up at your home.
So we'll talk later about boundaries, but Anupam, you mentioned something interesting, this idea of virtual check-ins.
Mm-hmm.
Anupam,
Yeah.
what is that?
Yeah, so I have
Oh
a
yeah, I'm at
niece.
the house.
I have a niece. Can everybody hear me?
Mm-hmm.
Yes.
Okay. So I have a niece who is bipolar at a very early age. She was diagnosed, and so my cousin at present has become her full job to take care of her. Right, left everything as such, taking her from one therapist to another, and being a proper caregiver. So what we as individuals, as extended care team at present in that particular case, we talk to her, right? Not only to my cousin, but to my niece regularly, both audio, video conversation, different types of, ways of when we meet her in person as well, to make sure that everything is okay, right? And we are there for them, right? If they need there's a supported, circle available, right? A circle of care, right? Available for them, which they can seek out for help.
So very good. And your family member takes advantage of this. She'll reach out to you.
Yes, and think it's both ways, right? So one is it's comforting for her that in case something happens, she can rely on a particular source, a trusted support, right? In a need, which destigmatizes to some process and reduces a burnout as well, right? To some extent. And then the second thing is for us as well, we also have a visibility in what is happening, and we feel more involved in the care of that individual.
Mm-hmm. Very good. That's excellent support. And it's not always there with family members, right?
Right.
So this next question is more about resources. So let me try to copy and paste it. Really appreciate all this great personal sharing that's happening. So this last question is there a history of chronic disease in your family or amongst your friends? What community health resources do they have easy access to? And which community health resources seem to be lacking. So for the folks and family and friends that you know that are challenged by chronic disease, what's available in the community and what's missing?
In my community, we're missing in emergency care. There's lack of providers, transportation to even get to emergency if need be. And we identify here a lot of hypertension and a lot of diabetes. And so having resources available like diabetes prevention program, in place where someone can go. I've taught diabetes prevention classes and had a great success with that. There's for hypertension, we have now we have like resources that they can go out and become more active and walking. We don't have like a great food resource here because a lot of time people have to buy what they can afford to eat. And when they get in that food, a lot of the food is not, healthy, and they can't really afford the healthy eating. So that's just some of the things for me, that's lacking here.
Okay, thank you. Any other ideas about what's present to support patients when they leave the doctor's office and what's a challenge to find? I spoke earlier about grief support. It really any psychological, there's a shortage of counselors and psychologists too.
Mm-hmm. It seems like healthcare providers, primary care physicians are all fading, and we're all teaming out, and the community health workers are growing. So one of the great resources is being a community health worker within that community, and anything that's available. That normally being a part of a community health worker can actually share those resources with a participant or a patient within their community.
Mm-hmm. I'm sure you have a paper binder and electronic folder about resources for people.
Absolutely. Have a whole book about everything that's near and far, as the need of the community arises. We kind of like update the resource binder, each maybe every 2 years to make sure that we are inclusive of everything that's, that's needed within the community.
Yeah. I had a meeting this morning with, okay, yeah, go ahead, Noor. Can you expound upon your comment?
Yeah, so I work with refugees, and so a lot of people that come over, they can't drive, and things aren't local necessarily. The weather's been quite pleasant, so yeah, they can, go to the shops with a bike or whatever, but as it gets hotter, that's going to become harder and harder. Language barriers, so like just being able to go to the doctor or taking their children to the doctor. There are a lot of services that are offered now, but it's that barrier. Do they, with the variety of languages, sometimes that's not easily it's not easy to get a translator.
Mm-hmm.
So that's what I found.
What are some of the common languages you're seeing?
So we have a large Afghani community here, and Asian, like Pakistani and
Mm-hmm.
those are the sort of communities that I've been working with. But yeah, there is just in general, and like they have different dialects, they have different,
Right,
it's not as easy as to say, oh, it's just a one language that they speak.
right.
So, it's a hard resource to get a hold of sometimes.
And does your agency have a language line?
They do, yeah, they use that sometimes, but again, it's not sometimes the languages aren't necessarily there.
Mhm. Yeah, I finished my career working in the prison system,
Mhm.
and that was the first agency I worked at that had a language line. And we providers really took advantage of it. We used it a lot. It's particularly with the Asian languages. We didn't have any expertise at all in Vietnamese or Chinese.
Yeah, and sometimes I lean on like Google Translate, but I know there's like a grammatical and social context that doesn't translate well.
Mhm.
So,
Yeah, thank you for sharing that. Which community are you in California?
oh no, I'm in Jacksonville, Florida.
Oh, wow. Okay. Thank you. Cheryl, I see your hand is up.
I just wanted to thank Nora for bringing that up because that is something that, I mean, we face on a pretty regular basis. My daughter is deaf. And so while interpreters and stuff are supposed to be provided, trying to find interpreters sometimes is almost impossible.
Let's see. This will be the last question. It kind of goes at the ecological model from the outer ring. The societal and political and the ring of laws, the legal realm. Oops. We've already done that one. Command C. All right, now Command V. Nope, I'll have to read it. It's not copying for me. So do you or a close family member have experience with chronic conditions? We established that, we all do. What do you notice the local governing institutions and politicians doing for their citizens with chronic diseases in your community? Have you or your group, the group you belong to or work for, had the chance to connect with these entities, with these governing institutions or politicians? Anyone have the opportunity to operate in that advocacy realm? There it is. There's the question. Any experience in our class about taking it to the policymakers? Taking our community health concerns to the policymakers?
I know living in a Republican state, sometimes people can be a little bit more closed off. They're not necessarily as receptive. They feel like people should be able to help themselves, and that these sort of issues are, that there's plenty of resources out there, and people are being lazy, and yeah, it's you kind of have to so some people are very receptive and empathetic, and then some people are completely not.
So name calling is blaming and just increases the stigma. Any positive stories out there about?
I'll just share with Merced, California, Merced County, through the ACEs Aware Initiative, first launched by Dr. Nadine Burke Harris, the
Yes.
first California Surgeon General, in relation to screening for ACEs, treating ACEs, and healing. and creating buffering supports of toxic stress, because it does address things like asthma, hypertension, diabetes, obesity, that sort of thing.
Philip, are we all aware of what ACEs are?
I'm sorry, ACEs stand for Adverse Childhood Experiences, and it was originally a study done by Kaiser Permanente and the CDC that was looking at obesity and what triggers obesity within certain groups. And so they narrowed down a study to a 10 questionnaire that focused on 3 areas, which had to do with abuse, neglect, household dysfunction. And from that study, it opened the door to seeing that adversity experienced in childhood could lead to high mortality rates and chronic health conditions. And so through the California state funding of the ACEs Aware Initiative, Merced County has received several funding opportunities, and we were able to create a informed network of care. And this group that has come together with different entities, we've been able to locally advocate with our county board of supervisors, our city council members, and our local government in trying to really create and push new initiatives within Merced County that is creating a community of resiliency. And so that's just some of the positivity coming out of Merced County right now.
Wow. So at the supervisorial level, the county supervisor level.
Yeah, we're taking it. So we first got funding for an education campaign. What are ACEs and how to treat them? And, talk to your medical provider about what ACEs are. And we had billboards, we had radio ads, we had flyers, we had, we educated the community in both English and Spanish. And from that led to another round of funding where we were able to create this informed network of care. And through the informed network of care, we're looking at addressing the chronic health conditions of our community. And we've identified that a lot of that comes from toxic stress that our families and our communities are experiencing due to food scarcity or paying their utility bills or whatever that might be, any kind of household dysfunction or abuse they might be experiencing. And so through the education campaign and the informed network of care, we've rallied the troops. We've had several medical providers become champions for this change in Merced County. Wow. And they've taken it to our city council and to our board of county supervisors, which has had a large focus on unsheltered population within our county. And now they're seeing a connection of people experiencing homelessness and being unsheltered due to adversity they experienced as children. And so we're able to connect the dots and we're getting more people to join the ranks. And it's just a really exciting time for Merced County.
Yeah, that is exciting. I wonder, it's so good to hear the doctors getting involved in that. I think if you brought that up in a community like ours, I don't know what we would do with it. I think people would say, I don't have enough social workers. I don't have enough psychologists to deal with that.
Right. And so through Medi-Cal is going through a revision, right? They're reshaping the landscape and shifting to, what is it, Cal-AIM it's going to be soon. Mm-hmm. And so part of the ACEs Aware Initiative is Medi-Cal reimbursement for screening clients, children and adults for adverse childhood experiences. But they're realizing the bandwidth of the medical providers, that their time is limited when they spend it with the client. And so that's why we've seen this workforce development through the state of California in hiring and funding all this community health worker work and ECM work. And so it's really creating this whole new shift in how we treat clients and work with clients. And the community health workers are going to be at the forefront in the trenches doing this work.
I think I see your hand, Leslie. I think the final session in this 6-week training is on trauma-informed practices. And I suspect there will be discussion of the adverse childhood experiences there. Okay, thank you. Thank you, Philip. Great sharing. Leslie? I saw your hand was up.
Yeah, thank you so much. I was just gonna piggyback, just, or just share based on what Philip just shared is a few years ago when I worked at a large health center in San Diego County, we implemented ACEs. But one thing we did when we implemented ACEs is that we actually had the majority of our employees, they were able to opt in or opt out. In doing the screening themselves, because we sometimes forget that, yes, we're screening the people in our community, but part of our employees were part of the community as well. And we knew that if they were asking these questions based on workflows that were established, they may have been triggered by the questions being asked.
Yes. Yeah.
And so it was just something, as Philip was talking, it just kind of reminded me of an initiative that I helped launch years ago at Neighborhood Healthcare in San Diego. And it was really big, really important. And there was some level of reimbursement that we had, of course, for our patients, not so much our staff, but we wanted to make sure we took care of our staff.
Right.
So that we can better care for the patients in our community. So that's all I had.
Yeah, we staff, we're part of the community as well. And I made a mistake like that too. I would say in 2015, I was working at Natividad Medical Center and I gave a presentation on ACEs before the topic was ready. And I brought along a copy of the ACEs survey that you're referring to, Philip. And as soon as I passed the survey out, no one paid attention to me anymore. They were just they were scoring themselves, So it was totally, as Leslie referred to, it could have been triggering, probably was triggering to half of the audience. So we have to have, if we're going to screen, right, a lesson is we have to have answers available for positive screens. Okay, so I think we worked our way through these series of questions linking our personal experience with chronic disease or a family member's experience with chronic disease and the various levels in the ecological model that impact the patient. We looked at the very end, we looked at the sort of local governance, policymaker level, and the tremendous success that Philip's group has had in Merced County. That's really remarkable. We spent a lot of time talking about the psychological aspects of disease and not so much, although there was some discussion about individual psychology, especially with diseases like schizophrenia and bipolar disease, but there was also talk there about lack of support and outright bad care that's given to folks with psychological illness. So we did work our way, and we talked about the pluses and minuses of family members and friends helping us. Although we didn't focus that much on the negatives, there's a lot of data out there about cultural reasons why family might not always be helpful, dare I say, might not always be helpful with the person struggling with chronic disease. But most of what I heard today was helpful family, and that's very encouraging and uplifting. So before we do this final part, which is kind of wonky, are there any more final thoughts about the ecological model and how it works and interconnects with chronic disease? I know we did have a pretty thorough discussion, and we'll talk a little bit more next week. So this last moment, we're going to talk about sort of the medical aspects that I think community health workers, or actually Tim thinks community health workers should know about one chronic disease in particular called hypertension. And we don't have to spend a lot of time on this. It is getting late, but I will work through this. And Maddie as well has a lot of experience with clients or patients with high blood pressure. We talked about the causes of high blood pressure a lot today. And remember, don't blame the patient. Remember that probably 75 to 80% of the reasons a person develops high blood pressure or has a hard time supporting themselves is outside of the patient's control. It's something about the ecology or the patient's environment. Who can tell me what the symptoms, it's kind of a quick trick question, I'll warn you ahead of time. Who can tell me some of the symptoms of high blood pressure? I'll give a hint. It's called the silent, it's often referred to as the silent killer. Are you with me, folks? You can use the chat box if you like.
Can we say a stroke or a heart attack?
Okay, Maddie is helping.
Blurred vision, headaches.
Yes.
Buzzing of ears.
Okay. What is
Anxiety.
Say it
Oh, I was
again.
just saying-
Anxiety, yep.
Yeah, anxiety,
sure.
depression. Yeah, we talked about that.
So let me phrase the question another way. What is the commonest symptom that a patient you're seeing with high blood pressure will complain of?
Headaches.
Tired.
So, see, I told you it was a quick question. The reason why it's called the silent killer is the blood pressure can be up to even stage 2, and the patient will be asymptomatic. So that's an important thing that you all should know. And it's only when they're at bullet point number 3, it's only when the patient is at the point of complications that they start to experience symptoms. And correct, T, or I can't remember your name, Shantiana, you're very correct that once they're at the complications point, they will start complaining of headache, dizziness, chest pain, stroke, right, Maddie?
Yes.
Yeah.
More of those symptoms are pretty much like what's being shouted out. Blurry vision, dizziness, headaches. Sometimes, there are some, like you say, asymptomatics. There are very functional hypertensive people walking around. They walk around unknowingly, that they have hypertension because they never go to the doctor. And once they get to the doctor, they probably at the stages where their kidneys are failing, they're about to have a heart attack and or a stroke because all of the internal damage is already done when they realize, hey, I'm sick. And, if you don't go and get those checkups and, your health screenings, this is very important to learn out, to find out what's going on, to know your numbers pretty much, to know what your numbers are, so that part, yes, absolutely.
So yeah, Lindsay wrote in the chat box, and she's 100% right. There aren't many symptoms to start with. So just like you were saying, Maddie, they won't start complaining of symptoms until they're at stage 3. So great. This part about how is the diagnosis made by the doctor will save for next session when we're going to talk about more in detail about how to take blood pressures, and we're going to talk about home monitors. But there are a number of criteria for making this diagnosis. And the numbers come from the blood pressure pump, the sphygmomanometer. How common is high blood pressure? So let's just percentage-wise throw out some percentages of the population have high blood pressure. It's a very common, I'll give you a clue. It's a very common chronic disease. Little bit high, Lindsay and Azucena. Little bit high. So the numbers that are out there are 60. So the number is more like in the 40% range, maybe 35 to 40% of the American adult population has high blood pressure or hypertension. But as we talked about early on, it varies in populations. In the African American population, the risk or the chance of being hypertensive is higher, probably in the 45 to 50% range. So it's more common in that population. And then curiously and interestingly, the percentage of hypertension is lesser in the Hispanic population or the Latino population. And those numbers are more commonly in the 35% range. So regardless, a lot of people have hypertension, and some populations worse than others, some populations better than others. Sort of, again, popcorn out there. What are common treatments that are used for hypertension, and what are common things that patients can do to stave off or to prevent hypertension?
Exercise, eating, proper eating, more vegetables, more portion sizes. We really don't need to eat as much as we do. That's just my opinion. There's a lot, and we don't have to have, like, you have to have all three or four portions of this every single time you eat. That's where we fat, because we just portion size. Overweight, not fat, overweight, my bad.
Yes, we have to be weight inclusive in our vocabulary. So weight, you mentioned diet. What else?
Limit drinking, don't drink alcohol.
Yeah, absolutely.
In the chat box, you got medication, less salt, less sugar, relaxing. You also have stress reduction.
Can you, let's see. I had a slide up. I had a slide up that one of the students in our last session shared with us. Can you see that slide?
Yes.
The one called How to Manage Your Blood Pressure?
Mm-hmm. We see it.
I believe it's in the module too. It's in the module as well. This particular slide. Oh my God. But yeah, that's what I'm getting at, is the common things other than medication. And I think you guys mentioned them all. Eating smart. I think I heard that from Michelle. Moving more. I don't know about managing weight. I think that's a little bit outdated. I think the message now is healthy eating, active living.
Right.
Don't focus in on the number, the weight number as much, because a lot of, even in the medical office, a lot of weight shaming happens. No nicotine.
Really? How about just movement? I find that a lot of the 50 and above population, male, female, doesn't matter. The movement slows down. Of course, everything goes south, but the movement slows down to such a point where, do you ever find yourself getting out the car and going, ugh? And then you lock in on that. So to me, that's a mental hiccup for you, because when you make that sound and you constantly make it, this brings you more into not the right direction. So when I get out of a car now, I refuse, because I'm gonna be 65. I refuse to make a sound. I don't care if I need to make it or not. I'm not making the sound, because it messed with my mental. So me not making the sound gave me more encouragement to continue to, keep pushing forward. Okay, I'm gonna be quiet.
Was that Michelle?
That's
yes,
me,
it was.
Yeah.
I hear you. I'm older than you, Michelle, and I hear you.
No, you're not.
And 100%, I am with you. I have to. I'm finding myself squelching my noises so my wife doesn't hear me.
Yeah. But it does something to the mental. It does something to your mental. If you don't make those noises, even if it takes a little longer to bend down first and then pull up, those little things, because I hang with women, we play tennis and stuff, and we get out the car and go to lunch, it just sounds like an orchestra.
And a
But the
lot of,
movement is my point. Movement. If you do more movement, just even sitting in a chair, moving your arms, moving your shoulders, just holding your chest, your back up. I find a lot of people over 50, they slouch, they drop, and their posture becomes very inhibiting.
yeah, there's a lot of literature out there specifically, Michelle, about Tai Chi. The benefits of Tai Chi with chronic disease.
I could see that.
Yeah. And then we talked about the nicotine before, and then a big one that patients can be doing without seeing the doctor that we can counsel, what we community health workers can counsel the patient about is sleeping well. Making sure that you're getting, as you get older, particularly 6 to 7 to 8 hours of sleep every night, turning off the light breaker, getting away from those little machines like iPads and telephones at night.
Oh, like this over here?
Yeah.
Like
So
we
that
doing now?
answers-
No.
So that answers the last question of what can there's a lot that patients can do to lower their blood pressure so that the doctor doesn't have to add that second or third or fourth medicine. And that's really in the wheelhouse or the bailiwick of community health workers. And I'll check the module to make sure this sheet is there. If it's not, I'll upload it. And then it's got other useful information for your patients or your clients with hypertension. So we made it through the first session on chronic diseases. Any additional questions that Maddie and I can share our experience about with this disease, with this condition called chronic disease? Okay. And so that's great. I know it's a lot of information, and I know it's almost 5 minutes to 8. So we're done. Is there it'd be great if someone in the group could lead us through a closing exercise for today's session.
And while you're doing that, could you please put your name in the chat box one more time for us to make sure that we have an accurate account of everyone that attended the class?
So the reverse of an icebreaker, how do we put a bow on today's class? I'll say, thank you for all the interactivity. You guys really, I'm really grateful for that. You made our job easier. Thank you for for putting up with my technical faux pas of not negotiating the breakout room well. I'll look into that and make it better for next time. Any gratitudes from you, Maddie, for our wonderful students?
Yes, I absolutely enjoyed each and every one of you. I have learned so much. You have educated me today as a community health worker. Y'all shared some information that I did not know. So every time we do these class, I learned so much from you all. Thank you all so much for your knowledge. You're welcome.
Okay,
Thank you all for sharing. It's just amazing.
So yeah, if you can, like Maddie said, just put your name in one more time, and thanks. And we look forward so much to spending time with you next week. Don't forget,
Absolutely.
I think you've probably got 24 hours more for your discussion forum. Okay.
Yes, please go into the discussion and post your discussion, and make sure you comment on someone else if you don't mind. And because we love to see what you have to say. It'd be so interesting. Thank you all so much. And if you put your name in the chat box, have an amazing rest of your evening, night, and we'll see you next time.
And I agree with you, Azucena. Staying positive. And that's an important thing when we're working with patients. It's real important to stay positive, that they can do it.
Amen. They will help the blood flow and help be happy, and it will help everyone stay positive.
Okay.
Absolutely.
Thank you.
Bye.
Bye-bye.
Great reminder. Okay. Oh my God, that breakout room. Jeez,
That was a challenge, wasn't it?
that never happened before.
That's okay. That's okay.